Hi, I'm Kevin Harrison. I'm an interventional cardiologist at Duke and director of the Duke Lab. I wanted to present a case where I think FFR measurements and pressure wire technology for making physiologic measurements in the coronary is particularly helpful for a lot of our patients. This particular case, I think, is a nice illustration of this technique. This is a 58-year-old person with long-standing diabetes who was referred to the cath lab for coronary angiography. The patient had been on dialysis now for about a year and was seeking evaluation for potential renal transplantation. The physicians who referred him for cath were concerned about the patient's compliance with medication, but wanted his coronaries looked at carefully to see if he had ischemic heart disease prior to renal transplantation. The left coronary angiograms were largely unremarkable. There were just some minor luminal irregularities. You'll see a still frame of the right coronary angiogram. There's some moderate stenosis at the proximal portion of the right coronary with a more severe stenosis in the mid portion of the right coronary, which was graded at about 70% stenosis by angiographic criteria. The issue with the patient's noncompliance came into some of the decision-making process for this case because we were concerned about the patient's ability and willingness to take dual antiplatelet therapy. After discussion with the patient's nephrologist, we decided to proceed with FFR measurement to see if the lesion was functionally significant. The stenosis severity in the mid-right coronary is the most critical issue, and the 14 thousandths pressure wire was placed in the distal right beyond the acute margin to make these measurements. To make these measurements accurately, the guide has to be slightly disengaged from the coronary, and the pressure wire sensor has to be extruded just distal to the guide catheter tip. Here you'll see the transition of the radio-opaque portion of the guide wire with the radiolucent portion of the wire where the pressure transducer sits. It's just distal to the guide catheter tip. You should make sure that you remove the wire introducer and completely close the Tuohy-Borst valve before you normalize the sensor at this point. Then the wire introducer can be reinserted, and then the wire advanced down to the coronary to the location that you're trying to measure. So the monitor now shows the guide wire tip position beyond the lesions in the right coronary to make the physiologic measurements. We found that intravenous adenosine is more reliable than intracoronary bolus injections. So in this case, the patient was given an intravenous infusion of adenosine, and the pressure measurements were repeated, and we'll show you those measurements here on the monitor. You can now see the physiologic pressure measurements. The guide catheter pressure signal is in red, and the distal signal is in yellow, representing the distal coronary pressure. With IV adenosine, you can see that there isn't a significant pressure drop across these coronary lesions with an FFR measurement of 0.88. So we felt confident at this point that there was not significant ischemia and that the patient did not need to proceed with coronary intervention. The patient was then recovered from the procedure and has done well in follow-up.